Hi everyone, my name is Christopher Dean. I am the Paediatric Red Cell Nurse Specialist here at UCLH, and I am also the lead nurse for the Red Cell Network for Education and Training in regards to red cell conditions. So today's training is the start of a rolling teaching program where we cover various topics over several weeks. But today we are going to be talking about sickle cell disease, the epidemiology, the inheritance, pathophysiology, misconceptions, and inequalities. These sessions will take about 45 minutes per session, and I hope you enjoy them. So first of all, let's have a look at what our learning objectives are. So by the end of this presentation, I'd like you to be able to understand the pathophysiology behind sickle cell disease and the disease process. Also, that candidates will gain further understanding of how sickle cell affects the body, and candidates will be able to explore and discuss health inequalities regarding sickle cell disease alongside common misconceptions and references to the all-party parliamentary group report called No One's Listening. At the end of the session, we'll provide you with a QR code or a link on the last slide in order for you to fill out a little quiz just so we can gain what knowledge you've understood from the session so that we can use those, evaluate those and see if we need to change anything that we're doing. We'll also be sending out a feedback form just so you guys can have some input about the session and whether we need to change anything or do anything differently. So as we all know, the most common place that sickle cell is prevalent is in sub-Saharan Africa or the western coast. However, there is, because of all the migration that's happening all over the world, which is a good thing, these genes are spreading out and more people are affected all over the world. So in Europe, we probably have about roughly 40,000 people. Do you guys know how many people in the UK are affected or have sickle cell? No, I want to talk, that's fine. So at the moment, we currently have about 15,000 people with sickle cell disorder in the UK. Number of births a year, we have 300 patients in the United Kingdom. Can you guys all see this moving along on the slides, like appearing and everything?
Yeah, we can.
Okay, awesome. In Nigeria, there's about 150,000 births a year. And trying to get data in America is quite tricky. So they just gave a statistic of 1 in every 365 births in Black or African American communities are affected by sickle cell. And it is estimated by 2050 the number of children being born with a sickle disorder shall increase by 30%. So these numbers are going to rise dramatically by the year 2050. Does anyone want to explain how sickle cell is inherited? Like what pattern it follows, how it is inherited?
An autosomal recessive disease.
Yeah, so autosomal recessive, awesome. So it's autosomal recessive, which you just said, which means that both parents have to have a copy of a sickle gene in order for the child to be affected. They might also be affected themselves, but the partner has to carry one of the genes. If parents are carriers, so they're not affected, there is 25% of the child inheriting both genes, which results in a sickle cell disorder. And if one parent is affected and one parent is carried, there's a 50% chance of inheritance. And logically, if both parents are affected, then 100% chance of inheritance for the child. Found a nice little diagram which explains that. It is important to know that over here in England, we have had incidents where parents have had their testing done back in their home country to find out what their status is, and they've been told they have HBAA, so they're not a carrier, they're not affected, there's no chance of passing it on. However, when we come over here, they have a child that's born with HBSS, so the most severe, most common form of sickle cell, and it takes a lot of work to try to tell them that maybe this testing wasn't as rigorously done, and false results are given. It does come as a massive shock to the families, understandably, to have their life turned upside down. They think they're having a healthy child with no problems. Now they're having a child with sickle cell disease that might pose problems.
Yeah, can I just add that
Yeah, of course.
that happens a lot, and I'm from Nigeria, so I know it happens a lot because the tests there are probably not done properly, and sometimes they're just inaccurate, and so it happens a lot. And the other thing is that I think I'm one of the consultants, by the way, so I'm not even sure whether I'm meant to be
Hi,
here.
Ollie. Yeah, you're
Hi.
fine.
But one of the things that I think is really important, explaining the inheritance, because I would say a lot of our parents feel that once they've had one child with sickle cell, that is their 1 in 4 chance. When actually you need to explain that with every single pregnancy. So there is another chance that 1 in 4. So you can have 4 children if you're going to have 4 children, and all of them have sickle cell. So it's really important to explain that, because I realized that having been with a mother who said, well, didn't I just have my chance of having sickle cell, and why have I got another child with sickle cell? So I think it's really important that we explain that to them in detail and make sure that they understand it.
Yeah, very valid point. Very great. I didn't even think of that actually, Ollie, as a potential to explain to parents.
That's just from experience. So.
Generally speaking, with our patients as well, if we know the parents are carriers or affected and they're planning a child, we do link them in with a geneticist who chats over all of this. So yeah, it goes without saying that perhaps we automatically assume let's discuss with a geneticist if they choose to go to see them. Interesting. That's going to change my practice as well. So as we have experts on the call, we know the different types of sickle cell. These are the main ones. There are other things in literature and research that we perhaps haven't seen or are aware that they cause some issues. So the HBSS, like I say, is the most common and usually the most severe. HBSC still causes problems. You don't necessarily see them in hospital as much. HBS beta plus FAL, HBS beta 0 FAL, HBSD, which is also known as HBS Punjab, HBSE, and these all, even though, say, a group of 5 patients have HBSS, it doesn't mean that condition is going to behave in the same way. They have different phenotypes, and we're not entirely sure why that happens yet. And we're doing this massive genome mapping thing called bioresource, where we're trying to look into what other genes come into play with sickle cell. Again, just a little nice picture just to demonstrate how it is all inherited, which gene from which parent, and how it manifests. So detection, again, as you probably all know, pregnancy screening for the mother to see if she carries the gene. We can also test the father. We offer CVS sampling, which is chronic villi sampling, which is similar to amniocentesis in a way that we actually take cells from the placenta as opposed to the amniotic fluid. And we prefer doing CVS sampling because we can get more cells and more accuracy, potentially. Amniocentesis, like I just said, we do it for a variety of different conditions. We take a sample of the amniotic fluid. Each of these tests come with a risk of miscarriage, so it's totally up to the family whether this is performed. Quite a small risk, but it can happen. Again, these tests aren't foolproof. I've recently had a patient where mum had amniocentesis done back in Nigeria and was told that likelihood is the child doesn't have sickle. And at the age of 2, we've just had to announce they have sickle. And we refer to a geneticist if needed or if the parent would like it. Postnatally, we do the Guthrie test, which is now called a newborn blood spot test, which tests for a variety of different metabolic inheritable conditions such as cystic fibrosis. And if positive, then further blood tests are taken to confirm. However, if we know, say the mum or the father is one of our patients and we know that their partner is a carrier, it's just a simple case of doing a blood test when they're younger to confirm everything. When they're born, sorry. So a little nice picture of the amniocentesis versus chronic villi sampling explains the differences. We did a chronic villi sampling earlier. As you can see, it's more of a fetus. It's earlier in stage in the pregnancy. So quick basic pathophysiology now for you guys. So haemoglobin, as we know, it is a mixture of Latin because we love Latin in medical terms. So it's from the Greek word haema, which means blood, and Latin for globus or bulb sphere, plus the ion at the end, because why not? And we know hemoglobin is a protein molecule found in the red blood cells, which helps carries oxygen. It's iron rich, and it helps oxygen go around the body. It's comprised of 2 alpha and 2 beta genes, and we know sickle cell is a beta chain disorder. So for those of you who aren't hematology trained or have an interest in hematology, for those of us that aren't affected and have no known hemoglobin variants, our HB is HbAA. A is for adult. For sickle cell traits, we have HbAS, so they carry one of the genes, but they shouldn't be affected by it, and they have one normal copy. So that if that child's born with HbAS or that parent has HbAS, they have the chance of passing it down to result in a sickle disorder. For a sickle condition, there is no adult hemoglobin there, so it will be HbSS, HbSC, 2 different hemoglobin variants that come together to present into a sickle cell disorder. And there's a nice little picture of hemoglobin for you with the different chains, the iron-rich molecules. Oh, that didn't show up how I wanted it to do, but hey-ho. So the average red blood cell, just going to quickly talk about how this is, and then we'll talk about the difference in the sickle red blood cells. So red blood cells are disc-shaped, they're flexible, so when they're going along all the small blood vessels, they can morph a little bit and squeeze through. Like I just said, it can pass with ease. Able to carry oxygen effectively around the body. And there's an average lifespan of about 120 days for an average red blood cell without any sort of hemoglobin variant. So conversely, the sickle red blood cell, that worked how I wanted it. Nice little crescent-shaped red cell there. So it's a sickle or C-shaped. The sickle is called sickle due to the old style gardening farming equipment when they're cutting down wheat in the fields, one of those sickle blades. And that's why it's likened to that. These cells are quite rigid, and it's difficult for them to pass through blood vessels. So they often get stuck and clump and cause vasoocclusion. And due to this, they're very ineffective at carrying oxygen. Once they've offloaded the initial oxygen, that's when they polymerize and cause these C shapes. So after that, they're pretty useless at carrying oxygen around the body. And the lifespan days are 10 to 20 days roughly. So they break down a lot quicker. Hemolysis happens a lot quicker and more often. And this is why our patients can potentially look a bit jaundiced if the liver can't keep up. I don't know if you guys have seen the national NHS communication pictures that have recently come out, where it says, "Can you tell it's sickle?" And it's just a picture of a person with sickle cell disease and showing their eyes, and I believe it is like a jaundiced sclera of the eye. It's quite powerful. It only came out a week or 2 ago now, and we're hoping to see that more across mainstream media to raise awareness. So briefly touched upon hemolysis before. So as you can see in the picture, it is just little where the red blood cells break down, become these little bits. But hemolysis is normal, you know, we all break down our red blood cells eventually. So after about 120 days or after any sort of illness. And this happens more quickly and more often in sickle cell, like I said. And this can lead to anemia and jaundice if the liver can't keep up. So I'm repeating myself a little bit there, but hey ho. This is why perhaps our patients have low resting hemoglobin if they're not on any sort of other disease modifying therapy that increases it. So like EPO, or sometimes hydroxycarbamide causes it. And in other conditions, so say we have someone with a malignancy, so like a leukemia, if their hemoglobin is trending down to like 68, 69, we'll be like, okay, you need to have a transfusion, but we don't necessarily do that in our patients because it's normal for them. So a little picture of how vasoocclusion happens now, which is the most common presentation to A&E with those with sickle cell. So stickiness happens, and this is because from an early age, sickle cells start to damage and inflame the blood vessels. Damaged blood vessels become irritated and activate selectins to be released. Selectins are sticky factors, or you can know them as sticky factors that cause the cells to stick to the vessel walls and to each other. And this causes issues after
a little while. And it causes clustering to happen. So as more and more cells interact with these selectins, the cells get stickier, get stuck together, and the vessel walls beginning to cluster. So as you can see in that picture just above clustering, you can see that the white blood cells are there, the platelets have got involved, red blood cells are there, and this causes a lot of pain for our patients, and hence why they usually come into A&E in pain. So once the cluster is big enough and it builds up, it becomes a blockage, which makes it difficult for blood and oxygen to flow normally. And this is known as vaso-occlusion. And this process is ongoing. There's a lot of background stuff happening as opposed to flare-up of acute vaso-occlusive pains. And due to this, this is why our patients have end damage in certain organs, which I'll go into briefly in a minute, and why the pain occurs. Obviously, I can't comment on what the pain is like. I do not have sickle cell disease. I can only take what my patient said to me and saying it's like being stabbed repeatedly or being worse in childbirth. Okay, so we're just going to go do a brief tour of the systems to say how it can affect it. Again, this is quite low, basic knowledge, just for those of you who don't know hematology or do hematology medicine or nursing. So pain, we just talked about how pain happens through vaso-occlusion and clustering, the blockages. The brain, does anyone want to comment on how the brain can be affected by sickle cell? Okay, so the brain, oh, sorry, go for it.
Basically, so one of the things that we do in all patients with sickle cell for children between the ages of 2 and 16 is we do transcranial Doppler monitoring. And this is really to look at the flow of blood over the main vessels in the brain, because the brain basically is supplied by several different vessels in the brain, and it's called the circle of Willis. So we look at the flow of blood and the velocities between over those different vessels by doing a non-imaging TCD, which basically is a probe that you put basically on the temporal aspect of the head. But sometimes because of bone attenuation, particularly in the older children, it's very difficult to get the velocities. And you can also do the imaging technique as well. So you look at the velocities, and we look at any velocity that's greater than 200, and we're worried that the children are at the risk of stroke. So at the moment, we don't really see that many children with stroke, but previously we used to before the screening program. And this is because the sickle cell basically blocks the flow of blood along these vessels. And once that flow is blocked, sometimes there are other vessels that basically are produced to also supply bits of the brain. But that when that happens with the blockage, bits of the brain cells actually stop working, and then you then have to develop other vessels, which obviously don't occur overnight, to try and reoxygenate that bit of the brain. So some of our kids have problems with cognitive ability, and also because they've missed lots of days off school as well, so it all affects their cognitive ability. So they have silent strokes, some of them have main strokes, some of them can have TIAs, and also just affecting their cognitive ability.
Perfect, thank you. It's always handy having a specialist consultant on the call. So yeah, as Ollie said, that's our main concern. We do have patients with silent infarcts, so we won't necessarily know it's happened, but we might see that their learning is a little bit delayed. And then we'll do an MRA heads, and then we'll find out, oh yeah, there's been some silent infarcts. We've had a case recently here at UCLH of one of our teenagers having a massive cerebral hemorrhage, who is perfectly optimized on hydroxycarbamide, never saw her in hospital. She was managing well at home, and then suddenly had this massive hemorrhage, and unfortunately she passed away. So it can be unpredictable. Lungs as well, there's a risk of acute chest syndrome, which later in the rolling teaching program we will be going over what that is, and it can lead to lung disease, lung damage, and it's life-threatening, that condition. Kidneys, as you can imagine, the sickling and the clustering and blockages can happen anywhere in the body. So all the vasculatures and vessels around the kidneys can become damaged, which can lead to kidney damage. and kidney failure. So one of the things that we do is monitor kidney function whenever we do their bloods. And we also, some of the medications we provide can also affect the kidneys. So some of our patients who have been on long-term transfusions, they need some sort of chelation treatment, which is where we give medication to get rid of the iron that we're giving them. That medication, we have to closely monitor their kidney function as well to make sure we're not messing them up. It's also important to note for those who are interested in pediatric sickle cell, our patients find it very hard to concentrate their urine. So nocturnal uresis, so bedwetting, happens quite often later as they get older. So it's completely normal. And that's something that we have to work with the families to make them aware that, again, an average child that doesn't have sickle cell, bedwetting will stop. But it's a bit more difficult for our younger population. Hips as well, we can have avascular necrosis happening. So we have patients in their 30s, even late 20s and their 30s that are needing hip replacements or surgery on the hips, just because of ischemia that's happening around that area, damaging the bones. So vessels, that's actually meant to be an eye. It's not the greatest picture in the world. But again, due to all the sickling and occlusions that are happening, it can cause sickle retinopathy and can cause damage to your eyes and your vision. We have some patients in their adulthood who have gone blind from retinopathy. The mind, our patients are also at risk of developing mental health issues, so low mood, anxiety surrounding their condition. We have a fairly robust psychological service for our adult population, which is available for them, and they just have to ask us for referrals. It's also important to note that in our demographic, our service users don't tend to mention it to too many people that they have sickle cell disease, and that's just a cultural thing. However, I think that's improving with our younger population. Males, in general, are at risk of priapism. For those of you who don't know what priapism is, it's a prolonged painful erection that, if it goes on, can cause major damage, can cause infertility later in life, and it's a medical emergency. So at UCLH, we are a urology specialist centre. So quite a few patients who are under our other teams get referred to us purely for urology's input. And our patients have to have aspirations, sometimes have shunts fitted, sometimes have to have prosthesis put in. And so for a young man in their early 20s, that could be quite devastating. And it can happen again and again and again. It can also happen in younger patients as well. So around puberty age, I have that lovely chat with them talking about their penis and potential issues of priapisms, which can be quite embarrassing and cringy for both of us, you know. But I still need to get a message across that this could happen and they need to look out for it. Females.
You can imagine how it is for a female consultant speaking about priapism. Right, it's even worse. So a lot of time it goes undetected because they don't tell us, they don't tell their parents, and they have maybe that it's happening at home, and then all of a sudden it's them quite prolonged. Whereas maybe if they told us that it was happening and it wasn't as prolonged, maybe we could have done something about it earlier.
Yeah, for sure. And just for you guys to know as well, recently we had a young man who came in, and when they actually aspirated about 200 mils of blood from his penis. And this happens purely down to sickling happening, so the blood is trapped in there. For females as well, quite a few of our adolescent and adult population, obviously the menstrual cycle happens every month if you're still having them or not on any sort of treatment, contraception, and that could affect it. So sickling can happen around menstrual cycle, and that's to know that every month you're going to go into a sickle cell crisis or have increased pain on top of your menstrual pain is horrible. It's like anticipatory pain. Ulcers as well can be an issue for our patients, purely because of damaged blood vessels, lack of oxygen getting to the legs. So if an infection steps in and causes an ulcer, it is very difficult to treat, and they can go on for ages. To our best efforts and months of tissue viability nurses, dressing changes, it's very difficult to heal them, and they are painful. So for those who are science-minded, I've done a little diagram here of what actually happens, a little bit fancier than the other pictures I showed you earlier. So at the top left, you can see an oxygenated red blood cell, and you can see after that, when it's deoxygenated, those little hemoglobin hexagons all polymerize, so they all join in the middle and become rigid, and that forces the cells to form those sickle shapes. And down here you can see that they're going through the blood vessels, and it gets stuck, they attract all the other cells and causes damage to the blood vessels, which can lead to infarction, hemolysis, and on the side there you can see all the different conditions that it can cause, so like acute pain, acute chest syndrome, hyposplenism, osteonecrosis, nephropathy, and all the other little bits and pieces. But we'll go into more on that in another of the teaching sessions if you join that. Misconceptions, just want to go through the common myths that you see. Only African ancestry can have sickle cell disease. That's a no. We know that it's genetic, so these genes can pass through various different cultures. We have patients from all over presenting sickle cell disease. There are Caucasian people with sickle cell disease, and they find it really difficult when they go into A&E and they tell them they have sickle cell disease and they're not believed. You know, it's quite rare, but it does happen. Sickle cell is contagious? No, of course it isn't. It's genetic. Sickle cell is a short-term condition? No, it's lifelong. This is like the questions that our patients get asked out and about because there's so little knowledge about sickle cell out there. They might have their VOCs if they're prone to them and have the pain, and that might make people think, okay, it's a temporary thing, it just comes up every now and again. No, it's lifelong. There's only one type of sickle cell? No, as we know, there are several types. Sickle red blood cells are the only cause for the pain, and no, that's not true. There's more to the story than just the sickle hemoglobin. Pain crises are actually the result of how sickle cell disease affects other components of the body's blood system, not just the red blood cells. People with sickle cell disease seek out opioids when they don't even need them. That's a common one, and a lot of prejudice happening around the world as our patients being drug seekers. So when they're having a pain crisis, which can be severe and require medical intervention, and it's a common complication of sickle cell disease, and these pain crises often require prescription pain medicine to provide relief. And they are opioid based, generally speaking, when they come into hospital. And then they're only coming in because they need it, because they're in so much pain. People with sickle cell disease are unmotivated and lack initiative. That's just complete nonsense. Sickle cell disease can affect the body, mind, overall life of people with the condition. There are health issues such as fatigue and anxiety, which may be misunderstood by others who don't know the symptoms of sickle cell disease. So a brief word cloud of what our patients get told when they come in the hospital. And there's going to be a lot more, but I didn't want to delve too deeply because I don't want to make our patients relive their past trauma or current trauma even. So our patients get told they need to be patient. They're not their only patient, you know. Some people feel like people with sickle cell are aggressive, they're horrible people, they're rude, they're bad, they get called racial slurs, they're opiate seeking, they're drug addicts. They're difficult patients to look after. People ask not to look after our patients. They're faking it, they're troubling, the pain's not that bad. You know, so if you come into A&E because you generally need help and you're brought or gone to say a DTH or something and ends up on a non-hematology ward, imagine how that must feel for them. We've actually had a patient wait 10 hours before for opioid analgesia in A&E because no one believed her. It's horrible. So briefly touch upon inequalities now, because I've got a few minutes left. So prescription charges, for those of you who aren't hematology trained, is sickle cell part of the prescription exemption list?
No.
No. And I do apologise if there are police sirens in the background. I live in South London. That is quite a common occurrence. So you're correct. So prescription charges, the government refused to add sickle cell patients to the free prescription lists. I don't understand how the government can so frequently challenge the existence of institutional racism whilst charging those with sickle cell for prescriptions, as said by one MP. Most patients are probably young, of working age, and have to pay their prescriptions. That's Maria Caulfield at the Trim the Sickle Cell debate back in 2019, which is disgusting, really, because if we think about what is classified as a medical exemption. You have conditions like epilepsy, which, as we know, is predominantly affecting Caucasian people. And there's a few other conditions as well, like diabetes. Like, our patients need their medicine, just like someone with diabetes needs their insulin. And to say that there's that prescription surcharge available, it's ridiculous, because that can still amount to like £100 a year. And our patients don't necessarily have that money. We know 45% of BAME, so Black and minority ethnic community, live in poverty in England, compared to 19% of the Caucasian population can live in poverty. So there's massive inequality there and disparity based on race, I feel. So briefly talk to you about what the different exemptions are. So diabetes, hypoadrenalism, a fistula, so someone with stoma, diabetes mellitus, hypoparathyroidism, myasthenia gravis, mixed edema, epilepsy, continuing physical disability, which means you cannot go out with the help of another person, and those with cancer diagnosis and later effects. So I just wanted to touch upon, I picked out a disease that, again, affects not only Caucasian people, but the majority of patients with this disease are Caucasian. I don't want to say one condition is worse than the other, because that's not true. I've done cystic fibrosis nursing, and I know how horrible the disease is, and there's a short life expectancy associated with it. But I just wanted to show you guys what the differences are in funding. So briefly, cystic fibrosis affects about 10,500 people in England, and it predominantly affects Caucasian, with 1 in 29 Caucasian people carrying the trait, but it is affecting other demographics and cultures. Approved treatments at the moment are 511 for cystic fibrosis. Compared with sickle cell disease, we know about 15,000 people in England have sickle cell disease, and it predominantly affects African/Caribbean, again, other cultures too as well, but that's the main culture. And 1 in 4 West Africans carry the trait. Again, it's very difficult to find data, mainly American-based. And currently the only approved treatments are 5. So that makes you wonder, is there more funding and more research happening by the big pharma? Is that happening because of a racial thing? Is it happening because of just more interest in certain conditions? Is there more money in one than the other? Who knows? So question for you guys, how much more funding as a percentage goes into cystic fibrosis for clinical care and services compared to sickle cell disease? Actually, not as a percentage, about how many times more?
I'll throw out 20, Chris. I'll give you a number.
Give me a number, thank you, Stuart.
Yeah.
Not far off, it's actually 30. So 30 times more funding goes into cystic fibrosis for care and various services. Then briefly touch upon blood donations. There's a current massive agenda going on to try to attract more Black donors. I'm not sure if you guys have heard of B Positive Cry, seen them in Britain's Got Talent, or you might just want to Google them. So they're doing all this amazing stuff to promote donors to come in, because our patients who are Black have rarer subtypes and can develop antibodies. So we're limited the amount of people that can actually donate blood and what units we can actually transfuse to our patients. So we're trying to drum up as a national thing to get more donors in. Briefly touch upon these inequalities that happen, and they're very sad cases. So I'm sure those of us who are hematology trained or have interest might have heard of Tyrone Airy. So here's a man with sickle cell disease who presented to his local hospital and unfortunately passed away. And it's claimed to be down to patient-controlled analgesia, not being monitored properly or following guidelines and policies. As far as I'm aware, he was admitted to a ward that's not specifically haematology trained, so maybe perhaps the policies weren't known of. There wasn't enough education and training related to sickle cell. Unfortunately, it resulted in his untimely death, which could have been avoided. And the big one recently, for those of you who have read the APPG, the All-Party Parliamentary Group report called No One's Listening, relates to Evan Smith. He is a young 20, I think he's 21 at the time of his death. He passed away due to some miscommunications and treatment not being initiated properly and handover between teams. So it might just be a case. His unfortunate passing is the reason for the APPG coming out, amongst other things, which highlighted inequalities in healthcare and lack of engineering training across professionals who do not specifically train in haematology. If you guys want to know more, please do look up the cases, but as I said, it's quite sad. I won't show you this one as I'm running out of time, but if you'd like to listen to a song or a rap song, it's called Hidden Pain. It's by an artist called A-Star, who has sickle cell himself and is on regular red cell exchanges. It's quite a powerful song that explains how people with his conditions are perceived and how he feels with the pain that he has. So I just wanted to open up the floor now to questions, if anyone has any. No question is stupid, nothing.
Are you what are you doing about the toolkit, because they launched it recently at the sickle cell awareness day, and there's now a toolkit, a sickle cell toolkit, and there are lots of things that have been said should happen. I think when CQCO comes around, they're going to look at things like that. They're making sure that when a sickle cell patient is admitted to the ward, that the hematology team are called. So there are loads of guidelines, and it was all from the APPG, I think. So are you trying to implement some of those things? There are probably things that are being done anyway, but I suppose in pediatrics, I think it's maybe easier. I don't know about adults.
Yeah, so as I say, Ali, pediatrics is a lot easier. They come in under one team, and then there's the CNSs and there's consultants like you, pediatricians and specialist interests in hematology. So we generally know our patients are coming in. In terms of local stuff for us at UCLH, we are in massive amounts of meetings at the moment with our A&E in order to see if we can make changes to our systems to streamline everything. So automatic alerts are in place. We know about when they come into A&E, the staff in A&E know that's a medical emergency if they present with pain and a 30-minute target. And we are also developing PGDs, so patient group directives, for the nurses in A&E to be able to give their first dose of opioids. In terms of a wider thing, as a network, myself, Stuart, who's our network manager, who's on the call, and Dr. Joshua, who's the lead for the network, we will be doing visits to other sites to see how we can help and improve things.
Is this for adults and pediatrics, or just
both? So in terms of my role, so I'm the part-time pediatric red cell CNS, and then the other time it's lead nurse for education and training across all patients. So kind of a mixed bag, but I'm pediatric trained by background. But in terms of the education and training bits and pieces, that's why I'm joining Emma and Stuart to visit. I think our first site visit is to Bedford soon in September.
Okay.
But if there's anything you guys need in terms of where you guys are, please do get in contact.
I think maybe I would say at North Mid, it's a very different pediatrics and adult services, because our kids never go to A&E, they come to our pediatric day assessment unit. And I suppose things like PGDs are probably quite useful there as well. And at the moment, I would say that it's kind of difficult to audit whether the patients have got their analgesia in 30 minutes, but that's one thing that we probably need to do. And maybe a PGD is very good. And we also have a sickle cell performance as well, and everything's kind of written on it, but it's whether they have to call a doctor who then comes to give it. The doctor might be busy dealing with an emergency. So it's better that there is a PGD so the nurse can give the, and I think that's probably something that we will probably develop as well. So that'd be really good.
Yeah, I mean, once ours is all set up and going, I know it's underway, but as you know, setting these up is massive for even just paracetamol.
Yeah.
So maybe once that's all done, we can have a chat and see if we can speed up the processes with you guys.
Yeah, that would be really good.
Yeah, that'd be awesome. But yeah, unfortunately, we don't have, for the adult population here, we have to see if there's space in our daycare unit to take them. And unfortunately, because they're so busy, because it's part of the cancer directorate and cancer division, quite a few of the review spaces that they have are taken up by febrile neutropenias or other sort of cancer related things, but we try our best. Is there any other questions?
I like all the sciencey bits and all the diagrams of your slides, so they were really good. Thank you.
That's right. Would you like a copy?
Yes, please.
Yeah, of course. If anyone would like them, please put a little message in the chat. Maybe pop your email address, because we know our email directory system is a bit of a nightmare. So please type it in the chat and then I can send it around to you. Please spread awareness of the Rolling Teaching program around your teams. And we are repeating the session on Friday at 3 o'clock. And then once we've done the full 7 weeks, we'll probably start again.
The problem is that I think most of the information is actually going to people that already have a lot of this knowledge anyway, and this should ideally be going to people that don't have the knowledge. So it should be going to nurses on the ward, other doctors, other pediatricians. So because when I got it, I sent it out mainly to my team members. I didn't really know, so I'm going to spread the word and send it out to everybody. And I think that's what the HCC needs to tell us, to say, look, spread this out to everybody, not just the hematology people, because that's who are on the emails. So actually we should spread it out to everybody. So I'm going to do that now.
Okay, perfect. Thank you, Ollie. Okay, awesome. Well, if there's no other questions, we are done.
I think
Thank you very much.
in the chat.
Oh, sorry, I could see
potentially
the chat. If there is another question, do you want to ask me?
It says the medication given by LAS prior to admission is considered as a first analgesia treatment. That's what it is asking. The question is the medication given by LAS prior to admission, is that considered as a first analgesia treatment?
So the problem with that, LAS are they differ wildly in what their practices are and what they give and what they can give. We've had patients who arrive just having Antonox in the ambulance, which is quite outdated. And sometimes they don't give anything at all.
I think this is a live question, Chris, actually, that's being asked wider as to when that initial analgesia, whether it's in the back of an ambulance or whether it's in ED. I think that's actually a live question that is being looked into.
Yeah,
as to
thanks,
when the clock starts. So yeah, I don't think we've got an answer to that at the moment.
Yeah, it's an ongoing question, because we're trying to standardize all of our policies and guidelines, aren't we, Stuart, at the moment?
Yeah.
Across all the different trusts. So can't give you an answer now, unfortunately, but hopefully soon we'll be able to. Awesome. Thank you very much, guys. Again, if you have any other questions, you can always contact me. I'm available. And this video will be uploaded to our network website. So again, if people can't make study days, they will be available for you guys to access easily and share around.
So would they, when you say network website, would the link be sent out to people as well, so that at least the people in the forum, because then we can also spread it out to our other people in the trust to make sure that they look at it, because the HCC, since the development of the HCC, so much education and work is being done. It mustn't be wasted. I think you guys are doing excellent work and making sure that the education is going around. But I think sometimes we're preaching to the converted, and we need to preach to the ones that are not converted and don't really know about sickle cell. And I think that's my concern, that it's not getting, it's not being looked at by people that are not aware of sickle cell. I'm sure a lot of people on this call are probably people that have an interest in sickle cell. So.
Yeah, I'm just wondering, Amina, would you be able to send around the link to the website?
Yeah, I can do that. Once I've uploaded the these sessions onto the website, I can send the link around for that to be shared.
Yeah, we've also uploaded other videos of the two big like all-day jobbies that we did, one for sickle and one for foul, and it's separated into the different speakers and different topics. So there's a fair whack of stuff on there already, but then we're doing these little bite-sized ones, like I say, so they can always pick what's most appropriate for them. But Amina will send those around.
Chris, sorry, have you answered Yan Lin's question that came through?
So it's transcribing, so it's just going up completely by itself.
So how do you differentiate between a vaso-occlusive crisis or a chronic pain from, for example, long-standing hip issues? Did you answer that? Or?
Oh, no, I didn't address that one, but it's very difficult. I don't know, Ollie, do you want to come in on that question?
Yeah, sorry, I asked that question. As you know, as a medic, we do get frequent reattenders, and to be cautious, I always try to treat it like a vaso-occlusive crisis and use the protocol, make sure we do bloods. But if this patient's coming in every day, going through that ordeal seems quite a lot for ourselves as well as the patient. Yeah. And then I don't want to mislabel it as chronic pain and dismiss the possible issue of a vaso-occlusive crisis. So I just wondered if you guys had tips on how best to manage these patients or what to look out for. Thank you.
Well, I suppose with children, they generally don't have a lot of chronic pain. I think if there is chronic pain, then normally you need to investigate to find out why they have chronic pain. Like, for example, you said the hip pain. So we would make sure that, so when our patients are seen, if they've got acute problems, they'll obviously be treated. If they're in acute pain, they'll be treated there and then. And if this pain is ongoing, they normally, when they're seen, they're generally referred to the outpatient clinic, and then obviously we would see a copy of the discharge letter, so we know that well, and obviously speaking to the parents and the child, will know that this pain has been going on for a long time, and then it will be further investigated. We have had children, though, a few children, not many, with chronic pain that we've had to refer to the chronic pain service at Great Ormond Street, and usually with some of it is they may have chronic pain, they have pain, but maybe it's exacerbated by what's going on either at home or school. And sometimes when you address all those issues as well, the pain actually is not as bad as it is in the mind of the child at the time. So those are one of the things. So we refer to our psychologists, we sometimes refer to the chronic pain team, we see what issues are going on at school or at home. So we kind of address everything holistically and not just the chronic pain itself. So I don't know whether that answers your question. In adults, it might be slightly more difficult, but in difference rather, but in children, that's what we generally do. So we have kind of like an MDT, and we discuss the what's going on generally in the patient's life as well, and also treat the acute pain when it first starts, and if it goes on to be chronic, look at things slightly further.
Thank you. I think my question applies to adults, and more from my point of view, the initial presentation in A&E, and if they need to be admitted overnight. I mean, if it's difficult to tell, I can continue to do what I'm doing and assume it's a vaso-occlusive crisis. But and I just wondered if you guys had any tips at the front door. And then obviously the haematology doctors will see them shortly within their admission, so they can maybe advise from there.
Yeah, I mean, it's always easier to get, if we are thinking it might be chronic pain, then it's always easier to get like a complex pain team review or chronic pain team review whilst they're an inpatient, depending on what services are available. Obviously, with like bony pain, we need to rule out things like osteomyelitis that might be triggered, or avascular necrosis. So I think the general advice would be treat as if it's a VOC at initial stages and then go from there. Sorry, I could give more of an answer to that one.
No, that's fine. That makes sense.
I'll discuss it with our consultants and I'll get back to you. I'll drop you an email. Right, perfect. Were there any other questions, Amina, that you spotted?
No, I think we've covered them.
Okay, perfect. Well, thank you very much, guys.